Patients with a stable angina usually present with a chest pain after certain level of exertion due to the presence of fixed narrowing of more than 70% of the coronary artery lumen. This type of pain is relieved usually by rest or by drugs like the nitroglycerine. On the other hand, patients with unstable angina present with increasing pain after less level of exertion or sometimes at rest, and that's why it's called crescendo angina. This happens usually due to plaque disruption and thrombosis, distal embolization of the thrombus, and or vasospasm. Those patients usually have fixed narrowing of 90% or more of the coronary artery lumen. Transmittal angina or variant angina. This type occurs usually at rest, and it happens due to coronary artery spasm, either on an existing atherosclerotic plaque or on completely normal vessel. This type responds to vasodilators such as the nitroglycerine and the calcium channel blockers. Myocardial infarction or heart attack. In this type of ischemic heart disease, necrosis of the heart muscle is caused by ischemia. It affects around 1.5 million per year. 1/3 die, and of those, half before reaching the hospital. Myocardial infarction happens after complete obstruction of the coronary artery lumen, means 100% occlusion. The most common scenario is caused by obstructive thrombus over a disturbed atheromatous plaque causing complete obstruction of the coronary artery, and this can cause massive myocardial infarction. Less commonly, in 10% of myocardial infarctions, infarction occurs in the absence of occlusive atherosclerosis, and it's related to vasospasm. For patients suspected to have myocardial infarction, certain laboratory workup, including the creatinine kinase MB isoform and the troponins, is ordered. Troponins and the creatinine kinase MB isoform have high specificity and sensitivity for myocardial infarctions. The creatinine kinase MB isoform, or what's called the myocardial isoform, is more specific indicator for the heart damage. Its activity begins to rise within 2 to 4 hours after myocardial infarction, peaks at 24 to 48 hours, and return back to normal within 72 hours. So after 3 days, creatinine kinase MB isoform will be normal even if the patient had myocardial infarction. Troponins, on the other hand, including troponin I and troponin T, are detectable within 2 to 4 hours, peaking at 48 hours and remaining elevated for 7 to 10 days. This means that after 1 week of myocardial infarction, troponins will still be positive if you do a laboratory evaluation. Clinically, patients with myocardial infarction presents with severe crushing chest pain that can be felt in the neck, shoulder, or even at the jaw. This type of pain is not relieved by nitroglycerine or rest, and it can be associated with sweating, nausea, dyspnea, shortness of breath, and sometimes vomiting. In 10 to 15% of cases, myocardial infarctions are silent, which means asymptomatic, particularly in elderly patients and diabetics. Complications of myocardial infarction include contractile dysfunction. In most cases, there is some degree of left ventricular failure, manifested as hypotension, pulmonary congestion, and pulmonary edema. Arrhythmia is another complication because myocardial infarctions lead to myocardial irritability and conduction disturbances that can cause sudden death. Approximately 90% of patients develop some form of rhythm disturbance. Myocardial rupture, which complicates only 1 to 5% of myocardial infarctions. Chronic progressive heart failure due to the multiple myocardial infarctions. The outcome for patients with myocardial infarction Those patients suffer from 30% mortality in the first year and 3 to 4% mortality per year thereafter.